Welcome, everyone, to the Radonc Smart Review GI Cancer series. We've really journeyed through the intricate landscape of anal cancer in our previous sessions, building quite a robust foundation.
Oh, really, yeah.
We've explored everything from the fundamental anatomy and epidemiology right through to pathology, workup, staging.
All the foundational pieces.
Exactly. And then we moved into those landmark trials, the ones that really established definitive chemoradiation as our standard of care. We even got into the nitty-gritty of IMRT planning.
The technical side, yeah.
So today, this is part 4, and it's crucial. Our mission is to synthesize all that knowledge and really dive deep into the critical post-treatment journey. This is, where the rubber meets the road.
It really is.
We're talking practical toxicity management, evidence-based follow-up surveillance strategies, and looking ahead, what's next in research.
That's right. Our focus today is squarely on navigating the waters after active treatment finishes. And frankly, that's often where the real challenge of comprehensive care truly begins for our patients.
Definitely.
So to really anchor our discussion, give us a framework. Let's think about a patient scenario, one that kind of encapsulates many of these immediate and also the long-term post-treatment challenges you'll face in practice.
Okay, sounds good. So let's imagine Mr. Davis. He's 55 years old. He's HIV positive, but, and this is important, his viral load is well controlled. CD4 count's good, 400.
So reasonably healthy baseline despite the HIV.
Exactly. He's in his final week of definitive chemoradiation for a clinical T3N1B anal cancer. And as you can probably guess, he's experiencing some significant acute toxicities.
Right at the peak time.
Yeah, specifically grade 2 perineal dermatitis and also grade 2 diarrhea. He's anxious, understandably so, right? Like many patients at this stage.
Of course.
And he asks us, what happens after I finish? How will you know if the treatment actually worked? And, what are the long-term issues I need to watch out for?
And Mr. Davis's questions, they're precisely what we need to address today. They really highlight a critical point for all of us in radiation oncology. Our role, it extends so far beyond just delivering the radiation beams.
It really does.
It genuinely encompasses managing the patient's entire experience, from those acute side effects during treatment, all the way through their, often complex long-term survivorship journey. It's about quality of life, isn't it? Not just the cure.
Absolutely. And while we've covered the anatomy, the epi, risk factors, pathology, workup, we did that in depth earlier in the series, Mr. Davis's questions bring us right into the practical realities of managing care after the diagnosis and the initial treatment plan.
Right. The what now?
Exactly. So let's start with his immediate concerns. He's in his final week. He's got this grade 2 dermatitis, grade 2 diarrhea. What's our practical, aggressive plan for managing these right now? How do we get him through these last few days smoothly?
Okay, good starting point. And you've hit on probably the most common dose-limiting toxicity right away, that perineal dermatitis. It can be incredibly debilitating for patients. Affects sitting, sleeping, hygiene, everything.
Yeah.
So for Mr. Davis's grade 2, that erythema, maybe some dry desquamation, our management starts with emphasizing rigorous, clean, daily water therapy.
Okay, what does that entail specifically?
Simple things, really, but they have to be done consistently. Regular sitz baths, using lukewarm water. They're incredibly soothing, help keep the area clean. We tell patients, sit in the bath maybe 15, 20 minutes, 2 or 3 times a day.
Okay.
Or alternatively, just using a simple peri bottle, the kind they give women postpartum. Use that for gentle cleansing after every single bathroom visit. It's crucial. It mechanically removes irritants without any harsh scrubbing.
And beyond the cleansing itself, how do we protect that irritated skin? Because friction must just make it so much worse, right?
Oh, absolutely. Avoiding friction is paramount.
Yeah.
So we advise Mr. Davis and all our patients, wear loose-fitting clothing. Think boxer shorts, not tight briefs. You want maximum air circulation down there.
Right. Let it breathe.
Exactly. And air drying the area after baths or using the peri bottle rather than, vigorously rubbing with a towel, that helps prevent more trauma. For the skin itself, we prescribe fragrance-free moisturizers. Apply them frequently, keep the skin supple, prevent cracking. And then a good barrier cream, something like a zinc oxide-based diaper cream or even just a plain petrolatum ointment. It's exceptionally effective at creating that protective layer, shielding the skin from moisture, from irritants. Apply it liberally, several times a day.
That sounds like a really solid first line for grade 2, but let's be real, grade 2 can sometimes progress pretty quickly to grade 3, moist desquamation. And that looks awful. It feels awful for the patient. It's a real challenge. What's our escalation plan if that happens?
Excellent question. And unfortunately, a very common scenario If we see it progressing to moist desquamation, where the skin is literally weeping, breaking down, we need to escalate immediately.
No.
A modified Dakin solution soak, done twice a day, becomes highly effective.
Dakin's solution? Explain that a bit.
Sure. Dakin's solution is basically diluted sodium hypochlorite, a very mild bleach solution.
Yeah.
It sounds harsh, but it's incredibly helpful. It cleans the area, reduces bacterial colonization, which is a risk for secondary infection.
Right.
And crucially, it helps debride any necrotic tissue and promotes healthy granulation tissue formation. So you soak a gauze or a soft cloth with the Dakin solution, apply it gently to the affected area for maybe 10-15 minutes.
Okay.
It's truly a game changer for those severe cases. It significantly speeds up healing and reduces pain. We can also use topical analgesics like lidocaine gels, maybe apply them before cleansing or dressing changes, just to help manage the pain.
You know, when I'm trying to remember all these steps for dermatitis, especially when things get tough, like with moist desquamation, I find mnemonics really help lock it in. I use one I call PD Care. Helps me cover the bases.
Oh, interesting. Let's hear it.
So P is for peri-bottle and clean water, that rigorous hygiene. D is for Dakin's solution, our go-to if it gets messy, right? C is for clothes, keep them loose, breathable. A is for air drying, let the skin breathe. R is for repairing the skin with those moisturizers and barrier creams. And E is for managing erythema and discomfort, maybe with those topical analgesics.
I like that, PD Care. That's actually quite comprehensive and easy to recall. Very useful.
Yeah, it helps me. Okay, so moving on to Mr. Davis's other issue. Grade 2 diarrhea, that can also be incredibly disruptive, especially in this final week. What's our strategy there?
Right, diarrhea. So first, we reinforce the low-residue diet. He should already be on that, hopefully avoiding high-fiber foods, dairy, spicy things. But beyond diet, medication is key.
Loperamide.
Exactly. He should already be on scheduled loperamide. It's vital to make sure he understands the dosing, how to titrate it. Patients can safely take up to 4 tablets a day, usually 2 milligrams each, spaced out, to control frequency and urgency.
Okay.
We usually start, say, 2 milligrams every 4 to 6 hours as needed, but we emphasize, if it persists, increase the frequency up to that maximum dose.
And if that's still not enough?
Good question. If loperamide isn't thudding it, or if there's significant cramping and urgency, we escalate to Lomotil. That's diphenoxylate and atropine.
Okay.
The crucial point here, from our perspective, the radiation oncology perspective, is managing this effectively enough to avoid a treatment break.
Right, because breaks are bad.
Breaks are bad. Severe diarrhea can lead to dehydration, electrolyte imbalances, or just make the patient too uncomfortable to come in for daily radiation. And a radiation break, even just a few days, can potentially compromise local control. You really want to deliver that prescribed dose as continuously as possible.
Makes sense. And speaking of managing things systemically without interrupting treatment, mitomycin C. It's often part of the chemo regimen with 5-FU for anal cancer, and it's known for being particularly myelosuppressive. Is that a concern here in the final week with cumulative effects? How do we manage that?
Yeah, myelosuppression is definitely a significant concern with mitomycin C, especially towards the end of treatment.
Yeah.
So for this, we're monitoring his weekly complete blood counts, the CBCs, very, very closely.
How often is closely?
Usually at least once a week, sometimes even more frequently if we see the counts trending downwards. The key numbers we're watching are the absolute neutrophil count, the ANC.
Okay, what are the thresholds?
If the ANC drops below, say, 750, or especially if it gets below 500, that's when we start getting seriously concerned about increased infection risk.
Right.
If it were to drop below 200, that's generally our critical threshold, where medical oncology would typically hold the chemotherapy dose for that cycle.
But the goal is to keep the radiation going.
Absolutely. Our goal, as you said, is to manage this very carefully to avoid interrupting the radiation schedule if at all possible. We might need dose reductions for the chemo or even hold a cycle of chemo. But we strive, really strive, to keep the radiation on schedule. Radiation breaks tend to have a more direct and often irreversible negative impact on local tumor control.
So chemo might pause, but radiation pushes through if feasible. What about things like GCSF, growth factors?
Certainly, prophylactic GCSF isn't routinely used in this setting. There are potential side effects, and again, the primary goal is to avoid radiation breaks. We tend to manage reactively by holding chemo if counts drop to low, rather than using GCSF upfront for most patients.
Okay, that makes sense. So that covers managing those immediate acute challenges to get Mr. Davis through. Now let's shift gears a bit. He's finished treatment, he's recovering, and he asks that huge question. How will you know if it worked? And this, This is where anal cancer really stands out, doesn't it, compared to almost any other GI cancer?
Oh, absolutely. It plays by its own set of rules.
Yep.
This next point is arguably the single most critical piece of knowledge that distinguishes anal cancer management from many others.
Okay.
One of the most unique and, frankly, quite fascinating aspects of anal cancer is its remarkably slow regression after treatment. It's not like, say, a lymphoma or even some head and neck cancers where you often see a rapid melt away within weeks.
Right, you expect quick results sometimes.
Exactly, but not here. This requires a significant amount of patience and, crucially, really clear communication between us and our patients.
So tell us about the evidence. Where does this wait-and-see idea come from, this 26-week rule that gets mentioned? Why is it so fundamental?
Okay, the 26-week rule, it is absolutely foundational, and it comes directly from the landmark ACT2 trial, ACT, spelled ACT. This was a big, multi-center, randomized phase 3 trial, published in a major journal, and it gave us invaluable prospective data specifically on response assessment in anal cancer.
And what did ACT2 show?
It showed something quite remarkable. At 3 months after treatment finished, about 50% of patients had achieved a clinical complete response, a CCR, meaning you couldn't detect the tumor clinically anymore.
Okay, 50% at 3 months.
But, and this is the key part, that number didn't plateau there. It actually rose dramatically up to 90% by 6 months. That's 26 weeks.
Wait, 90% from 50? That's a huge jump between 3 and 6 months. That's genuinely remarkable.
It is. And maybe the most striking piece of data from ACT2, the part that really drives our practice, is that 72%, nearly 3/4 of patients who still had clinically detectable residual disease at 11 weeks post-treatment. They went on to achieve a CCR by the 26-week mark without any additional treatment.
72% with residual disease at 3 months still got a complete response by 6 months. Wow.
Exactly. Think about that. A significant chunk of patients who still had something palpable or visible at 3 months ultimately achieved a complete response if you just gave them more time.
Okay, so what does that mean for managing patient anxiety during those months? How do you counsel Mr. Davis when he wants answers now and you're telling him, we need to wait maybe another 3 months?
That 72% figure is incredibly powerful for counseling. It directly informs our clinical approach and, maybe more importantly, how we talk to patients. Because of this compelling evidence, the 2025 ASTRO Guideline, ASTRO, pronounced like the word astro, makes a strong recommendation. Perform close monitoring for approximately 6 months after chemoradiation before performing a biopsy or initiating salvage therapy for what might simply be a slow-resolving tumor.
So the guideline explicitly says wait 6 months before biopsy unless something's clearly growing.
Essentially, yes. Unless there's clear evidence of progression, patience is the recommendation.
Yeah.
You know, I often use an analogy for patients, trying to explain this.
Yeah.
Think of it like developing an old-school photograph in a darkroom. Remember those? Well, when you first put the paper in the developer, you might see faint outlines, right? And an initial image starts to form. That's like the early tumor regression.
Okay.
But the full, crisp image, the complete picture of success, it doesn't fully emerge until you give it enough time in the chemical bath. You wouldn't pull it out after just a minute and say, oh, it failed, would you?
No, you'd wait.
You wait for the full development time. Our treatment response in anal cancer is remarkably similar. It's a slow reveal. It requires patience and understanding this unique biology. So we counsel patients like Mr. Davis right from the start. We have to be patient. We need to give the treatment time to work fully. It's like watching a slow-motion replay.
That's a great analogy, the photograph.
And we explain that what might feel like residual disease is often just the slow clearing of inflammation, maybe some necrotic tissue. Jumping to a biopsy too early carries real risks, unnecessary procedures, delayed healing, maybe even triggering the need for a colostomy that wasn't actually needed.
Okay, that really emphasizes the need for patience, backed by strong evidence. So for the majority, that 90% who do get that clinical complete response by 6 months, what does their surveillance look like after that? How do we monitor them long term? We want to catch recurrences early, but without over-testing, right?
Exactly. For complete responders, we follow a specific, structured schedule. It's designed to balance that early detection with patient convenience and avoiding unnecessary anxiety. First, physical exams are absolutely paramount in anal cancer surveillance.
Still including the DRE?
Absolutely. Always includes a careful digital rectal exam, the DRE, and very thorough palpation of the inguinal nodes, both sides. Why? because local recurrence in the anal canal and regional nodal recurrence in the groin are common patterns of failure, and they're often palpable before they cause symptoms.
Makes sense. How often?
We do these exams every 3 months for the first 2 years. That's pretty intensive, reflecting that higher risk of recurrence early on. Then, as the risk gradually decreases, we can space those visits out to every 6 to 12 months for years 2 through 3. After year 3, maybe optional annual follow-up for years 4 and 5 and often beyond, depending on the individual patient and local practice patterns.
And what about imaging during surveillance? Are we doing regular CT scans? Is there a role for MRI or PT scans?
Yes, cross-sectional imaging is definitely a key component. Primarily, it's looking for distant metastases, liver, lungs, or maybe deeper regional nodal recurrences in the pelvis that we might not feel on exam.
Okay.
We typically recommend a CT scan of the chest, abdomen, and pelvis at least annually until year 2. Minimum. Some guidelines or practices might go longer, maybe out to 3 or even 5 years, but at least 2 years of annual CTs is pretty standard.
And if something looks iffy on the CT?
Right. If we see any equivocal findings, maybe a questionable little spot in the liver or a slightly prominent retroperitoneal node, or if the patient develops symptoms that make us worried about the pelvis, then a pelvic MRI or a PT-CT can be very useful to further characterize those findings, to figure out if it's recurrence or just benign post-treatment changes.
Got it. And speaking of PT-CTs, how do we use them for that initial response assessment? We're waiting clinically until 6 months, but is there a role for PET earlier, maybe around 3 months?
Yeah, this is a bit nuanced, and how we use PT for response assessment has evolved. The first restaging PT scan is typically done around the 3-month mark post-treatment. This often coincides with that first follow-up visit where we do the endoscopy and the DRE.
Okay.
Now, if that 3-month PT scan shows residual FDG avidity, meaning there's still metabolic activity in the tumor area that could represent persistent cancer,
You don't panic.
you do not panic. Because of everything we just discussed about ACT2 and slow regression, if there's residual FDG avidity, but clinically things seem stable or improving, and there's no clear progression, we don't jump to conclusions.
So what do you do?
The standard approach is often to repeat the PT scan, maybe in another 3 months, so around the 6-month mark, to see if that avidity is resolving. The key is to avoid premature biopsies or salvage surgery based only on early PLE findings.
So the ASTRO Guideline addresses this.
Yes, the ASTRO Guideline is clear. It says PT scans at 3 to 4 months can help identify patients with persistent FDG avidity who might be at higher risk, and maybe that prompts closer follow-up or earlier reevaluation around 6 months. But it does not recommend immediate biopsy or salvage based on an early PL alone. It helps track the trend, but it's always interpreted in the context of that 26-week clinical rule, given the tumor time.
Okay, that clarity on using PT is really important. So we've guided Mr. Davis through treatment. We've outlined how we'll monitor his response. But his final question was about those long-term issues I need to watch out for. This brings us to survivorship care. It's our final responsibility, really, to prepare him and all patients for potential long-term effects. What are the key areas we absolutely need to counsel them on?
Survivorship care it's just paramount.
Yeah.
And it covers several really significant areas that can profoundly impact a patient's quality of life long after the cancer is gone. First and foremost is anorectal dysfunction.
Okay, what does that encompass?
Well, many patients, even if cured, will experience some degree of long-term changes in bowel function. This can range widely. It might be long-term fecal incontinence, maybe minor issues like trouble controlling gas or slight soiling, or it can be significant challenges that really impact daily life. It can also involve fibrosis, a stiffening of the tissues down there, making bowel movements difficult, causing urgency or that feeling of incomplete evacuation, tenesmus. And then there's stenosis, which is a narrowing of the anal canal itself, which can cause pain and difficulty passing stool.
These sound like they could be really devastating to quality of life.
They absolutely can be. They impact self-confidence, social interactions, everything. In fact, data from the big RTOG 9811 trial showed that about 5% of patients ultimately needed a permanent colostomy, specifically because of these late treatment-related effects.
Wow, 5%. That's not insignificant.
Not at all.
Yeah.
It really underscores how severe these late effects can be. So we absolutely need to counsel patients proactively about these possibilities, provide dietary advice, talk about bowel regimens, medications to manage symptoms, and crucially, consider referrals to specialists like pelvic floor physical therapists.
Okay. What about sexual dysfunction? That's often, the elephant in the room. It's deeply personal, impacts relationships, but maybe not always discussed openly.
You're absolutely right. It's vital we address this openly, proactively, and sensitively. Pelvic radiation, just by its location, impacts the nerves and blood vessels in the pelvis that are crucial for sexual function.
For both men and women.
Yes. For men, it can lead to erectile dysfunction, changes in ejaculation. For women, it can cause vaginal dryness, pain with intercourse dyspareunia, and very importantly, vaginal stenosis. That's a narrowing and shortening of the vagina due to radiation-induced fibrosis.
So how do we approach this conversation?
We need to have a frank, open discussion with every single patient. Normalize it. Make sure they feel comfortable bringing up concerns. If they are struggling, referral to specialist is often the next step.
Like who?
Could be pelvic floor PT again. They work on muscle function and flexibility. Sex therapists for psychological support, relationship counseling, urologists for men, gynecologists for women, for medical management, things like medications for ED or lubricants and moisturizers for women.
And you mentioned vaginal stenosis specifically for women.
Yes, and this is critical. Counseling women on vaginal stenosis and the importance of regular vaginal dilator use is a non-negotiable part of survivorship care. It really is. We instruct them how to use dilators, starting several weeks after treatment ends, and continuing regularly, long-term, to maintain vaginal pliability and prevent severe narrowing that can make intercourse impossible or pelvic exams difficult.
So it's a proactive measure they need to engage in.
Exactly. It empowers them to take an active role in managing a potentially difficult side effect, and it can make a huge difference to their long-term quality of life and intimacy. We cannot understate the importance of this counseling.
That's a really crucial point. Okay, moving slightly away from the direct pelvic structures, what about other potential issues, musculoskeletal things? I think I've heard about hip fracture.
Yes, that's another often underappreciated late effect. Patients getting pelvic radiation, especially for anal cancer, where the dose often includes parts of the bony pelvis, the ischial bone, sometimes the femoral heads, they're at an increased risk of pelvic insufficiency fractures, including hip fractures.
Why is that?
The radiation, over time, can weaken the bone structure, make it more brittle. So we should actively recommend adequate calcium and vitamin D intake as just part of their routine long-term health plan, support bone health, mitigate that risk.
Should we be screening them, like with DEXA scans?
In some cases, yes. A baseline bone density scan, a DEXA scan, might be considered, especially for older patients or those with other risk factors. And if they have osteopenia or osteoporosis, then interventions like bisphosphonates might be indicated. It's a simple preventative measure, but preventing a hip fracture is incredibly important for maintaining independence and quality of life.
Definitely. And one last area for younger patients, infertility. Is that something we need to address?
Absolutely. And ideally, this conversation needs to happen before treatment even starts, during that initial consultation phase.
Because pelvic radiation
can cause permanent infertility. It can damage the ovaries in women, the testes in men. So the opportunity for fertility preservation, sperm banking for men, egg or embryo freezing for women, needs to be presented clearly and facilitated before chemoradiation begins.
And if that didn't happen?
Well, it's a missed opportunity, unfortunately. But it's still a long-term implication for these survivors that they should be aware of, and supportive resources can still be discussed even after the fact. This really speaks to the need for that truly holistic, comprehensive pre-treatment counseling process.
Okay. Shifting gears again. The field is always evolving, isn't it? Anal cancer treatment isn't static. What are some of the key ongoing trials looking at, say, dose optimization, trying to improve that therapeutic ratio, maximizing cure, while minimizing these side effects we've just discussed? It sounds like we're moving towards more personalized radiation doses.
We absolutely are. There's a significant shift towards personalization, trying to tailor the dose to the individual patient and tumor characteristics. And there are several really exciting developments happening right now. One of the most comprehensive programs is the UK Plato program. It's actually a platform of related trials, ACT3, ACT4, and ACT5, all focused on personalizing the radiation dose. ACT is pronounced ACT.
Okay, tell us more about ACT4 and ACT5 specifically. What are they looking at?
Sure. So ACT4 is focused on dose de-escalation for patients with intermediate risk disease, specifically T1 to T2, node-negative tumors. It's comparing a reduced dose 41.4 gray to the standard dose, which is typically 50.4 gray.
And the hypothesis is?
The idea is that maybe these smaller node-negative tumors don't actually need the full standard dose. And using a lower dose could significantly cut down on long-term toxicities without compromising the excellent cure rates we already see for these stages.
Any early result?
Yes. The early results that have been presented look very promising. They suggest the reduced dose is well tolerated and achieves similar excellent clinical complete response rates. If the full study confirms this, it could mean significantly less toxicity, better quality of life for a large group of patients.
That's great. And ACT5, is that going the other way?
Exactly. ACT5 is looking at the other end of the spectrum. Dose escalation for advanced disease. For those larger, more challenging tumors, like Mr. Davis's T3N1B case, it's exploring doses up to 61.6 gray.
Trying to improve local control for tougher cases.
Precisely. The goal is to see if a higher dose, delivered maybe as a simultaneously integrated boost using modern IMRT techniques, can improve local control and potentially survival for these bigger tumors, while still keeping toxicity manageable.
So we're seeing both sides. De-escalation for early stage, escalation for advanced, a truly tailored approach. Are there similar efforts happening elsewhere, maybe in the U.S.?
Absolutely. Another really important trial, this one from the U.S. cooperative groups, is the DECREASE trial. That's EA2182. It's also rigorously testing dose de-escalation for T1 and T2 and 0 anal cancer, much like ACT4.
What's unique about DECREASE?
What's interesting about DECREASE is that it also includes a de-intensified chemotherapy schedule. So it's looking at reducing both radiation dose and chemo intensity for this favorable patient group.
A double de-intensification.
Right. Trying to hit that therapeutic ratio from both angles. If successful, it could be truly transformative for managing early-stage patients, offering potentially excellent outcomes with substantially fewer side effects. These trials really represent a major global effort to fine-tune our doses based on risk.
Okay. And what about immunotherapy? It's such a hot topic everywhere in oncology. Anal cancer seems like a prime candidate, right? Especially with this strong HPV link.
Immunotherapy is definitely a fascinating and rapidly evolving area for anal cancer research, and you hit the nail on the head. The HPV link is exactly why.
How does HPV make it a good target?
Well, HPV-associated cancers, which account for the vast majority of anal cancers, often express viral proteins. These proteins can be recognized as foreign, as non-self, by the patient's immune system. This makes the tumors inherently more immunogenic, potentially more susceptible to immune attack.
So checkpoint inhibitors might work well.
That's the hope. Checkpoint inhibitors work by releasing the brakes on the body's own immune system, particularly T cells, allowing them to better recognize and attack cancer cells. So several trials are actively investigating adding these agents to our standard chemoradiation backbone for locally advanced disease.
Can you name a couple?
Sure. For instance, trial EA2165 is looking at adding nivolumab, which is a PD-1 inhibitor. Another trial called Taranis is investigating atezolizumab, a PD-L1 inhibitor combined with chemoradiation.
And the goal is to...
The hope is that by harnessing the immune system alongside chemoradiation, we can improve long-term outcomes. Maybe increase the rate of complete responses, perhaps overcome resistance in some patients, leading to more durable cures. It's a really significant prospect for potentially enhancing our standard treatments, and definitely something we're watching very closely as the data matures.
Okay, that was a lot of ground covered, from immediate side effects to long-term survivorship and future research. Let's try to distill this down now into some absolute essentials, like the high-yield clinical pearls that people should really lock in.
Absolutely. Let's nail down the key takeaways. The non-negotiables for managing these patients, whether you're prepping for boards or making decisions Monday morning in clinic.
Okay, pearl number 1. What is it?
Pearl 1. You absolutely must review the new 2025 Anal Cancer Guidelines from ASTRO. That's ASTRO. Pronounced ASTRO. They're your primary evidence-based roadmap. Don't just skim it. Seriously, sit down, grab a coffee or whatever, and read it cover to cover. It pulls together all the latest evidence on everything from workup to follow-up. It's your compass.
Got it. Read the ASTRO guideline. Pearl number 2.
Pearl 2. Acute toxicity management is critical, not just for comfort, but for treatment integrity. For severe perineal dermatitis, remember PD care, or at least remember sits, baths, and decant soaks are key interventions. They make a huge difference. Don't underestimate simple measures.
Right.
And for severe diarrhea, the absolute priority is to hold the concurrent chemo if necessary before it forces a break in the radiation schedule. Keep that radiation going if at all possible. Continuity is paramount for local control.
Okay, pearl number 3. This seems like a big one based on our discussion.
It is. Pearl 3. The 26-week rule. This is foundational. Comes straight from ACT2, pronounced ACT. Response can be slow. Think of that developing photograph analogy. You must wait up to 6 months, 26 weeks, to assess for final clinical complete response before you jump to a biopsy for what you think might be residual disease. Patience isn't just a virtue here. It's evidence-based medicine.
Avoids unnecessary interventions. Okay, pearl number 4.
Pearl 4. Late effects counseling is essential. Proactive counseling and management are key for long-term quality of life. The big ones you have to discuss are anorectal dysfunction, incontinence, stenosis, fibrosis, then sexual dysfunction, and critically for women, you must counsel on vaginal dilator use. It's non-negotiable survivorship care. And lastly, don't forget the increased risk of hip fractures. Recommend calcium and vitamin D. Comprehensive survivorship care is vital.
Excellent. And the final pearl, pearl number 5.
Pearl 5. Keep an eye on future directions. This field is moving. Know about the ongoing trials like the UK Plato program, ACT45, and the Decrease trial. They're investigating dose de-escalation for early stage and dose escalation for advanced disease. The goal is always optimizing that therapeutic ratio, better outcomes, less toxicity, more personalized treatment. Stay informed.
Those are fantastic pearls. Really captures the essence of today's discussion. Okay, you ready for a quick board blitz? Test your knowledge on these concepts?
Bring it on. Let's see what you've got. Ready for the challenge.
All right, case 1. We have a 70-year-old woman. She has a T2N0 3-centimeter anal canal cancer. She finishes definitive chemoradiation, gets 50.4 gray. At her 12-week follow-up, so 3 months post-treatment, you do a DRE, an endoscopy. You note some residual firm ulcerated tissue at the primary site. What is the most appropriate next step? Is it A, immediately schedule an abdominoperineal resection for salvage? B, perform a biopsy of the residual tissue immediately? C, continue close surveillance and reevaluate in another 3 months? Or D, add a brachytherapy boost to the residual disease?
Okay, T2N0, 12 weeks post-treatment, some residual firmness and ulceration. The answer has to be C, continue close surveillance and reevaluate in another 3 months.
Right.
It goes right back to Pearl 3, the 26-week rule based on ACT2. We know clinical complete response can take up to 6 months. She's only at 3 months. The description is just residual firm ulcerated tissue. It doesn't say it's clearly progressing or growing larger than baseline. So the standard guideline-based approach is patience. Continue close surveillance. See her back around the 6-month mark. Jumping to biopsy B or salvage surgery A right now is premature and could lead to unnecessary major interventions if this is just slow regression. A brachy boost to D isn't standard practice here either. So C in clear answer.
Perfect reasoning. Okay, case 2. You're designing an IMRT plan for a patient. They have a T3N1A anal cancer with an involved inguinal node. According to the 2025 ASTRO Guidelines, which of these represents an appropriate dose painted prescription using SIB-A 45 gray to all volumes? B, 50.4 gray to the primary, 45 gray to all nodes. C, 54 gray to the primary and the involved node, 45 gray to the elective nodes. Or D, 59.4 gray to the primary, 54 gray to the involved node, 50.4 gray to elective nodes.
Okay, T3N1A with involved inguinal node. Looking for an appropriate SEB prescription per ASTRO. Let's break it down. T3 needs a dose likely in the mid to high 50s gray range. Involved node, N1A, needs something like 50.4 to 54 J. Elective nodes need around 36 to 45 J. Option A is too low overall. Option B underdoses the involved node. Option D might be okay for the primary and involved node, but 50.4 to elective nodes is higher than typically needed and increases toxicity risk. Option C looks like the sweet spot. 54 gray to the primary and the involved node, gross disease, and 45 gray to the elective nodes. That fits perfectly within the ASTRO recommended ranges for a risk-adapted sick approach. So the answer is C.
Excellent breakdown, exactly right. Last one, case 3. Which of the following is not a standard component of the elective clinical target volume, or CTV, for a squamous cell carcinoma of the anal canal? Is it A, bilateral inguinal nodes, B, mesorectum, C, para-aortic nodes, or D, presacral space?
Okay, what's not usually in the elective CTV? Bilateral linguals, definitely in. Mesorectum, yes, standard. Presacral space, yes, also standard. Para-aortic nodes, no. Those are generally not part of the standard elective volume for anal canal cancer. They'd only be included if there was known disease there, or perhaps in very specific high-risk scenarios, but not routinely electively treated. So the answer is C, para-aortic nodes.
Fantastic. Nailed all 3. Okay, let's just quickly recap the absolute key takeaways from today. First, that 2025 ASTRO guideline really is our bedrock, providing a clear evidence-based framework for managing anal cancer today. And second, proactive, aggressive management of those acute toxicities, dermatitis, diarrhea, it's just crucial to avoid treatment breaks and keep patients on track.
Absolutely. And third, remember that post-treatment surveillance has to account for that unique, slow regression of anal tumors. That 6-month window before assessing final response is critical. Patient saves colostomies sometimes. And finally, comprehensive survivorship care isn't an afterthought. It's absolutely essential. Managing long-term effects like anorectal and sexual dysfunction is key to supporting our patients' quality of life long after treatment ends. It's truly about treating the whole person.
Well said. We really hope this discussion has provided a solid foundation and some practical, actionable insights for your clinical practice as you manage these often complex but also very rewarding anal cancer patients. Remember, the journey definitely doesn't end when the radiation stops.
That's right. And you can get show notes and complete practice world boards over at radonsmartlearn.com. That's radonsmartlearn.com. And please subscribe to Radon Smart Review so you don't miss our next episode. Thanks so much for tuning in.